Welcome to the Funnel Effect.
It's great to be here.
Today we're doing something a little bit different. Normally on the show we're all about the latest breaking news, the cutting edge stuff that was published like 5 minutes ago.
The ink is barely dry.
Exactly. But today we're going to travel back in time a little. We're going to look at a monument, a piece of research that really sits in the bedrock of modern interventional cardiology.
Mm-hmm.
This is the kind of study that, well, it changed how doctors think, how hospitals are run, and at the end of the day, how patients survive.
Absolutely. In the world of medical research, there are papers and then there are landmarks. This is a landmark, no question.
And because this is just a massive piece of work, I really want to start by honoring the sheer scale of the collaboration here. This isn't just one doctor in a lab somewhere.
Oh, not at all.
This is a battalion of researchers. So I'm going to read the full credits because they absolutely deserve it. We are digging into the paper titled Benefits and Risks of Abciximab Use in Primary Angioplasty for Acute Myocardial Infarction, the Cadillac Trial.
A classic title. You just hear that and you know you're in for something serious.
And the authors are, and bear with me here, this is quite a list, James E. Cheng, David E. Canzari, Cindy L. Grimes, David A. Cox, Mark B. Efron, Eulogio Garcia, John J. Griffin, Giulio Guagliumi, Thomas Stuckey, Mark Turco, Martin Fahey, Alexander J. Lansky, Roxana Marin, and Greg W. Stone.
Wow. That is a staggering lineup. Just listening to those names, you're hearing the leadership of the Duke Clinical Research Institute, you're hearing the Cardiovascular Research Foundation in New York,
Right.
plus major centers in Spain, Italy, and all across the U.S. This represents really the heavyweight division of cardiology coming together to answer a single burning question.
And that question is about the highest stakes imaginable. We're talking about acute myocardial infarction, AMI.
Or as everyone else calls it, a heart attack.
A heart attack.
Yeah.
The Widowmaker scenarios.
That's right.
I want to really set the scene for you so we aren't just talking about abstract numbers and, p-values. Imagine the scenario. It's a Tuesday morning, someone is at their desk, or maybe they're out mowing the lawn, and suddenly there's that crushing pressure.
The elephant on the chest.
The elephant on the chest, the sweat pouring down, the arm going numb, that impending sense of doom people talk about.
It's a visceral, absolutely terrifying experience.
Your ambulance is called. Sirens are screaming. This is a race against time. What is actually happening inside the body at that exact moment?
Well, ideally, blood flows through your coronary arteries like water through a clean pipe, nice and smooth.
Okay.
But in this scenario, a plaque, which is a buildup of cholesterol and, well, gunk, has ruptured. It's cracked open. The body sees this rupture as an injury, and it does what it's supposed to do. It sends platelets rushing to the scene to form a patch.
Like a stab.
Exactly like a scab. But inside a tiny artery, that patch becomes a clot, a thrombus. And it can grow so fast that it completely blocks the pipe. Blood flow to the heart muscle just stops.
And the moment that flow stops, the muscle begins to die.
Instantly. This is where you get that phrase, time is muscle.
Time is muscle.
Precisely. Every single minute that artery remains closed, irreversible damage is being done to the pump of the heart.
Now, we aren't in the dark ages. We do have a solution for this. We have what's called a gold standard treatment.
We do. It's called primary percutaneous coronary intervention, or PCI. Most people would know this as angioplasty or stenting.
Walk us through that. What does that actually look like?
So the interventional cardiologists, they go in through an artery. Back in 2003 when this was done, it was usually the groin. Today, it's often the wrist. They thread a long, thin tube called a catheter all the way up, navigating through your blood vessels right to the heart. They find the blockage using X-ray dye. They cross that blockage with a very fine wire, and then they use a balloon to physically smash that clot and plaque open.
Just brute force, basically.
It's a very elegant kind of brute force, but yes. And often they'll leave behind a metal scaffold, a stent, to prop the artery open and keep it from collapsing again.
So it's a mechanical solution to a biological problem.
That is the perfect way to describe it.
And we know opening the artery is good. That's established science. It saves lives. But the core question of this deep dive and the Cadillac trial itself is, can we do it better? Can we make it safer? Because, like you said, the body is trying to clot. And then we go in there and start smashing things up, which creates even more injury. So the body wants to clot even more.
Exactly. You're poking the hornet's nest. So the question becomes, can we add a chemical weapon to our mechanical one? Can we flood the zone with something that just stops the blood from clotting while we work?
And that's where this drug comes in, Abciximab. also known by the brand name RioPro.
Abciximab is a very, very special drug. It's an incredibly potent antiplatelet agent. It belongs to a class of drugs called glycoprotein IBA inhibitors.
That's a mouthful.
It is.
Yeah.
But the mechanism is actually really cool. If you think of a platelet, that little blood cell that causes clotting on its surface, it has these little receptors, almost like tiny Velcro hooks.
Okay.
Those are the glycoprotein IBA receptors. When the platelet gets activated by an injury, these hooks pop out and then grab onto a molecule called fibrinogen, which acts like the glue. This lets all the platelets stick to each other.
So they link up arm in arm to form a chain or a net.
A net is a great way to think of it. And that net is the clot. Abciximab is basically a custom-designed antibody that binds directly to those Velcro hooks. It plugs them up.
It puts handcuffs on the platelets.
That's the perfect analogy. It handcuffs them. It blinds them. Even if they're activated and want to stick together, they physically cannot.
So the logic here is, if we're going in to smash open this blockage with a balloon or a stent, let's also flood the system with this platelet handcuffs drug to prevent any new clots from forming while we're working. It's like an insurance policy.
That is the exact hypothesis. And at the time of this study, which was published in 2003, we knew this strategy worked pretty well in unstable angina, which is sort of a stuttering pre-heart attack condition.
Right.
But for the full-blown acute heart attack, the data was actually a bit fuzzy.
Fuzzy how? What does that mean?
Well, the previous studies were either too small to be definitive or they didn't follow patients for long enough. Some showed a benefit, some didn't. So the medical community was left with this very expensive, very potent drug asking, is this actually necessary for every single heart attack patient? Or is it, overkill?
And that brings us to the mission of our deep dive today. We are going to analyze the massive Cadillac trial. We're talking 2,082 patients. That is a huge sample size for this kind of question.
It's enormous. And what we're going to see is a really fascinating conflict, a conflict between the short-term wins, what happens in the first 30 days, and the long-term reality of what happens after a full year.
It's a classic story of winning the battle, but,
Yes.
well, it won't spoil the war part just yet.
And we also have to get into the weeds of trial design. Because, interestingly, this huge study showed different results than another famous trial from that era called Admiral. Understanding why those two studies disagreed is where the real detective work begins.
I love a good medical mystery. So let's unpack this. Part one, the setup. Designing the Cadillac. First off, I have to ask about the name Cadillac.
Right.
It sounds fancy and implies luxury, top-tier performance. But I'm guessing it's an acronym.
Oh, it is. Medical researchers absolutely love their acronyms. It stands for Controlled Abciximab and Device Investigation to Lower Late Angioplasty Complications.
Okay, there is no way they didn't work backward from the word Cadillac to get that.
Almost certainly. But the Cadillac moniker, it implies top of the line, and that's what they were going for. They wanted a definitive answer. They wanted the Rolls-Royce, or I guess the Cadillac of clinical trials.
So set the scene for us. We're in the early 2000s. This paper comes out in 2003. What's the scientific landscape like?
At that time, stents were becoming the standard, but balloon angioplasty by itself is still very common. We knew that abciximab helped in what we call high-risk angioplasty, but for the acute MI, for that heart attack patient right there on the table, we just didn't have a massive randomized trial comparing everything side by side.
So how did they design this thing to get the ultimate answer?
They used a really brilliant structure that we call a 2x2 factorial design.
2x2 factorial.
It's the engine of the study. And it's brilliant because it lets you answer two big questions at once without needing twice as many patients. It's very efficient.
Okay, so walk us through the four groups. We had these 2,082 patients. How are they being divided up?
Okay, imagine a square divided into 4 boxes. Group 1, the top left box, got just the balloon angioplasty, no stent, no drug. This is sort of the old school control group.
Got it.
Group 2, top right, got balloon angioplasty plus abciximab. Group 3, bottom left, got a stent alone. Specifically, it was the multi-link stent. And Group 4, the bottom right box, got the whole package, stenting plus abciximab.
I see. So by comparing these groups, you can isolate the effect of the stent versus the balloon by looking at the rows.
Mm-hmm.
And you can isolate the effect of the drug versus no drug by looking at the columns.
Exactly. You can look at the drug effect by pooling everyone who got the drug, whether they got a stent or a balloon, and comparing them to everyone who didn't. It's a statistically very powerful way to do things.
So who were the patients? We know they were having heart attacks, but what kind?
Yes, specifically they had to have an ST segment elevation MI or a STEMI. These are the really serious ones where the EKG line goes way up, which indicates a total blockage of an artery.
Right.
They also included people with a new left bundle branch block, or LBBB, which on an EKG is a surrogate for a massive heart attack.
Now, were there people they left out? Because usually in these big trials, researchers try to pick the perfect patient to make the results look as clean as possible.
They did have exclusions, and this is actually crucial for interpreting the results later on. They excluded patients who were in cardiogenic shock.
And what is cardiogenic shock for our listeners?
That's when the heart is so damaged from the attack that it literally cannot pump enough blood to keep the body alive. The blood pressure tanks, the organs start to fail. It's a death spiral.
So the sickest of the sick.
The absolute sickest of the sick. And Cadillac excluded them because they wanted to look at the procedure itself without all the noise of patients dying from just overwhelming pump failure. They also excluded people with very, very tiny arteries or massive long blockages that were hard to fix mechanically.
Okay, so we're looking at a standard severe heart attack population, but not the ones who are actively, circling the drain from shock.
That's a good way to put it. It's a middle-of-the-road heart attack population. Not the minor ones, but not the absolute catastrophes either.
And the drug protocol itself, this wasn't just a pill they swallowed, right?
Oh no, Abciximab is heavy artillery. It's given intravenously. First, a bolus, a big dose pushed all at once of 0.25 milligrams per kilogram of body weight, followed by a 12-hour continuous drip infusion.
12 hours?
Yeah. You want to keep those platelets paralyzed for a good half a day after the procedure to make sure nothing bad happens while the initial healing begins.
All right, so they've randomized over 2,000 people. They've done all the procedures. Let's look at the scoreboard. Part 2, the 30-day results. You called it the victory lap.
And it really was a victory lap. When they looked at the data at 30 days, the results for Abciximab were, they were clear as day.
Okay, give us the headline stat.
The headline is that treatment with Abciximab significantly reduced what they call the composite endpoint.
The composite endpoint. That's classic researcher speak for a bucket of bad things, isn't it?
It's a bucket of bad things. In this case, the bucket included death, reinfarction, which means having another heart attack, stroke, or needing urgent revascularization, which is having to go back and fix the artery again.
So any one of those things happening counted as a failure.
Correct. And here are the numbers. In the control group, the ones who didn't get the drug, 7.0% of patients hit this wall. Something bad happened.
Okay, 7%.
In the Abciximab group, only 4.6% did.
So it drops from 7 to 4.6.
Yeah.
That's a difference of 2.4 percentage points. That doesn't sound massive on its own.
But in relative terms, it's huge. That is a relative risk reduction of roughly 35%. If you're a cardiologist and I tell you there's a drug that can drop your major complication rate by a third,
You're using it.
you're using it. The p-value was 0.01. That means it's statistically very significant. This wasn't just a fluke of chance.
But here's where it gets really interesting, right? We have to drill down into that bucket of bad things. Did it save lives? Did fewer people die in the drug group?
No. When they looked at death by itself, the rate was basically the same between the two groups.
Okay. What about strokes? Did it stop strokes?
Also, no. The stroke rates were very low in both groups and statistically identical.
So, if it didn't reduce death or strokes, what drove that big 35% reduction? What was the drug actually doing?
The real hero here, the thing that drove almost the entire benefit, was the reduction in ischemia-driven target vessel revascularization, or TVR.
PVR.
Well,
Unpack that for us.
It basically means the patient didn't have to be rushed back to the cath lab because the artery clogged up again right after the procedure. In those first 30 days, the arteries treated with Abciximab stayed open much, much better than the ones that weren't.
So it's preventing the bounce back. The patient goes home, they feel good, and they stay home, rather than coming back to the ER with chest pain 3 days later.
Precisely. And this links to one of the most stunning, truly stunning stats in the entire paper. We have to talk about subacute thrombosis.
This is the scary one, right?
It is the interventionalist's nightmare. You finish the procedure, you take a final picture, the artery looks beautiful, it's wide open, everyone in the room high fives. But then a few hours or a few days later, a massive clot forms on the stent or on the injured vessel wall. It shuts the vessel down instantly. It's often catastrophic. It can cause a huge second heart attack or even death.
And what did Abciximab do to this nightmare scenario?
It crushed it. It annihilated it. Look at the specific subgroup of patients who got a stent plus Abciximab. The modern therapy...
I'm looking at the table on the paper right here. The rate was 0.0%. Is that a typo?
0.0. In the stent plus Abciximab group, which was over 500 patients, not a single one had a subacute thrombosis. The drug essentially eliminated this specific deadly risk in the short term.
That's incredible. I mean, 0.0% is a number you almost never see in medicine. There's always one outlier, one person who has a weird reaction.
It just speaks to the sheer potency of the drug. If you put in a stent, which is a foreign metal object that the body wants to attack, and you don't adequately inhibit the platelets, the body's going to try to claw it off. Abciximab just says no, full stop.
But with great power comes great.
Bleach?
Even risk? I mean, it's a super potent blood thinner. If you cut yourself shaving while you're on this stuff, are you in big trouble?
That was the big fear. That was the trade-off everyone was worried about. But the safe verdict from the trial came back surprisingly positive. There was no increase in severe bleeding or, most importantly, intracranial hemorrhage.
Bleeding in the brain, that's the one that's game over.
Right. It's the complication we fear most, and it didn't happen more often with the drug. Now, there was a minor downside. Mild thrombocytopenia was more common.
Thrombocytopenia. Remind us.
A low platelet count. Basically, the drug works so well at binding to platelets that sometimes the body's cleanup crew, the spleen, sees these coated platelets and clears them out of the system.
Huh.
So in the drug group, about 4.5% of people saw their platelet count drop compared to only 2.3% in the control group.
Is that dangerous?
It can be if it gets critically low, but in this trial, it was almost always mild and manageable. Usually you just stop the drug infusion, the count recovers, and it didn't lead to catastrophic bleeding outcomes. So overall, at 30 days, Abciximab looked like an absolute home run.
A clear winner. It makes the procedure safer, it stops the clots, and it keeps patients out of the cath lab.
Yes.
So if we stop this deep dive right here, the conclusion would be, give this drug to everyone, it's magic.
If we stopped at 30 days, yes, that would absolutely be the conclusion. But the genius of the Cadillac trial is that they didn't stop there. They followed these patients for a full year. And this is where the story gets really, really complicated.
Part 3, the one-year twist, or as I like to call it, the great convergence.
Convergence is the polite mathematical way of saying the benefit vanished into thin air.
So they followed these patients out to 1 year.
Yeah.
Did that beautiful 35% benefit hold up over time?
I'm afraid not. By the time they got to 12 months, the event curves, the lines on the graph tracking bad outcomes had converged. They were sitting right on top of each other.
Give us the numbers.
In the control group, 18.4% of patients had a major adverse event by 1 year. In the Abciximab group, 16.9% had an event.
18.4% versus 16.9%. That looks, I mean, that sounds statistically insignificant.
It is. The p-value was 0.29. In statistical terms, that's a coin toss. There was no difference between the groups at 1 year.
Wait, I don't get it. How does a drug go from being a mic drop victory at 30 days to being a complete wash at 1 year? Did the drug just stop working?
Well, the drug itself is out of the patient's system within hours or days, but the effect should have lasted, theoretically. The reason for this convergence is the fundamental biological difference between thrombosis and restenosis.
Okay.
And this is the critical aha moment for understanding this entire paper and really a huge chunk of cardiology.
All right, let's break this down for everyone. Thrombosis versus restenosis.
Okay, thrombosis is clotting. It's soft, it's messy, it's made of platelets and fiber all clumped together. It happens fast, usually in hours or days. Abciximab, our drug, is the ultimate weapon against thrombosis. It's an anti-clotting drug. That's why the first 30 days look so fantastic.
Okay, got it. Thrombosis is a clot. So what is restenosis?
Restenosis is scarring. When you stretch an artery with a balloon or you implant a metal stent, you are injuring the vessel wall. It's a controlled injury, but it's an injury nonetheless. And the body tries to heal that injury by growing new tissue over it, like a scab, but on the inside of the artery. Smooth muscle cells migrate there and they multiply. This process is called neointimal hyperplasia.
So it's like the vessel wall itself is getting thicker and thicker, and it starts to encroach on the channel, narrowing the pipe all over again.
Exactly. But this is not a clot. It's tissue. It's meat, not blood. And here is the absolute kicker. Abciximab does not stop scar tissue growth. It's an antiplatelet drug, not an anti-scarring drug.
I see it now. So the drug prevents the clot, which is the immediate problem.
Yeah.
But it does absolutely nothing to prevent the scar, which is the long-term problem.
You've got it. So as the year went on, month 3, month 6, month 9, 9 patients in both groups, whether they got the drug or not, started developing this scarring process, this restenosis, at pretty much the same rate. And this late noise from restenosis eventually just drowned out that beautiful, clean, early benefit of the drug.
That is a fascinating and kind of frustrating distinction. The drug creates a perfect safety net for the immediate procedure, but it can't change the fundamental long-term healing response of the body.
And they proved this. It's not just a theory. They had an angiographic substudy. They actually brought 656 of these patients back 7 months later and took another X-ray picture of their arteries.
And what did the picture show? Was there any difference?
None. The drug had absolutely no effect on the artery narrowing. The minimum luminal diameter, which is just a fancy way of saying the width of the open channel, was the same in both the drug group and the control group.
So the drug protects the plumbing from clogging up with sludge immediately after you fix it. But it doesn't do anything to stop the pipes from slowly rusting shut over the next year.
That is a very, very good analogy.
Okay, this brings us to a really important point, part 4, the comparative analysis. Because as you mentioned, Cadillac wasn't the only sheriff in town.
Right. We have to talk about the Admiral trial.
Admiral, another one of these great, strong acronyms.
The Admiral trial was a similar study published around the same time, but it showed something completely different. It showed sustained long-term benefits for Abciximab. In Admiral, the drug group did better at 30 days and at 6 months and at 1 year. The curves never converged.
So what on earth is going on?
Yeah.
Why the difference? Why did Admiral get this long-term win while Cadillac saw all the benefits just fade away?
This is where we really get into the detective work. It's why we do these deep dives. There are 3 main theories that the authors and the community have kicked around for years. Theory number 1 is the simplest. Timing is everything.
The timing of the drug, how is it different?
In our Cadillac trial, patients got the drug right on the table in the cath lab, basically minutes before the balloon went up into their heart.
Okay, so they're already at the hospital, they're prepped, they're in the sterile room.
Exactly. But in Admiral, the patients got the drug much, much earlier. Often they got it in the ambulance or as soon as they hit the door of the ER. On average, they got the drug about an hour before the procedure even started.
An hour? Does 1 hour really make that much of a difference?
In the world of heart attacks, where time is muscle, an hour is an eternity. Think about what's happening. If you give this potent drug an hour early, it starts working on the clot immediately. It starts breaking up those microclots that have embolized downstream into the tiny capillaries.
Ah, so it's not just opening the big pipe, it's cleaning out the smaller ones too. The soil was better prepared.
The soil was better prepared? That's perfect. By the time the doctor even gets in there to take a picture, the vessel might already be slightly open. You get better flow before the stent even goes in, which leads to better muscle survival, which in turn leads to better long-term outcomes, like less heart failure. Cadillac missed that early window by waiting until the patient was on the table.
That makes a huge amount of sense. It suggests the benefit of the drug is incredibly time-dependent. Okay, what's theory number 2?
Theory number 2 is about protocol differences, specifically regarding something called bailout.
Bailout. That sounds like a financial term or something a pilot does when their plane is going down.
In medicine, it means Plan B. In the Admiral trial, the protocol was pretty strict. If you were randomized to the control group, the no-drug group, you generally stayed there, no crossing over. But in Cadillac, they were a bit more permissive. They allowed for bailout use of Abciximab.
What does that look like in practice?
Okay, so say you're the doctor performing the procedure in the Cadillac trial. You have a patient who's in the no-drug group. You put the stent in, but then a huge, ugly clot forms right in front of your eyes. The artery is shutting down. The patient's blood pressure is dropping. The protocol allowed you to say, okay, this is getting dangerous. I am bailing out. I'm grabbing the Abciximab off the shelf and giving it now.
Ah, I see. So the very sickest patients in the control group, the ones who were actively crashing on the table, ended up getting the drug anyway.
Exactly. About 10% of the control group in Cadillac got bailed out. And what this does is it contaminates the results. It dilutes the difference between the two groups. It makes the control group look better than it really was because its worst cases were rescued by the very drug being studied.
That is such a tricky part of trial design. It's the right thing to do ethically. You have to save the patient in front of you, but it completely messes up the clean statistics of the trial.
It's the classic conflict between individual patient ethics and the purity of scientific inquiry. And then you have theory number 3. The patient mix was different.
How so? Who are the patients in Admiral?
Admiral included sicker patients. Specifically, they included those patients with cardiogenic shock. Remember, Cadillac explicitly excluded all the shock patients.
And the thinking is, maybe the drug works best on the very sickest people.
That is a very strong possibility. It's a go big or go home argument. If you have a massive, messy clot burden that's causing the heart to fail and the patient to go into shock, a super potent blood thinner is going to have a huge life-saving impact.
Right.
But if you have a smaller, simpler heart attack in a stable patient, the benefit might be more marginal. It's like using a bazooka. If you're fighting a tank, like cardiogenic shock, you need a bazooka.
Oh.
If you're fighting a mosquito, like a small heart attack, a bazooka is probably overkill and might just make a mess.
So Cadillac, by being the Cadillac of trials and picking cleaner, more stable patients, might have accidentally designed a study that was less likely to show a benefit.
It's possible. By picking the Cadillac of patients stable, good anatomy, no shock, they might have minimized the very problem the drug is best at solving.
Fascinating. It really just shows how the design of a study, who you include, who you exclude, the timing, the protocols, can completely dictate the answer you get at the end. It's not just about the molecule, it's about the context.
Context is king in clinical trials, always.
Let's move on to part 5, subgroups and nuances. Diving back into the Cadillac data, was there anyone who did seem to benefit long-term?
Any little pocket of patients where the curves didn't converge?
There was, and you have to dig deep into the appendices of the paper to find it, but there was one subgroup that popped out. Patients who were having their heart attack in the coronary artery, or RCA.
The RCA. Why them? What's special about that artery?
In that specific group, the benefit of Abciximab appeared to hold up even at 1 year. It was statistically significant. Now, we have to be extremely careful here.
Dr. Chang and the authors are very clear about this in the paper. This could just be a statistical fluke. It's what we call the play of chance. If you slice and dice the data enough ways, diabetics versus non-diabetics, smokers versus non-smokers, men versus women, left artery versus right artery, one of them is bound to look positive just by random luck.
It's the danger of data dredging, right?
Yeah.
If you look hard enough, you'll find something.
Exactly. But if we were to speculate, if we were to put on our hypothesis-generating hats, why the right coronary artery? Well, the RCA is interesting anatomically. It often has a slower flow pattern than the left side. It supplies the electrical system of the heart, the AV node, so RCA heart attacks often come with bradycardia, a slow heart rate. It's at least plausible that the clotting dynamics in this slower, more tortuous vessel are somehow more susceptible to being fixed long-term by Abciximab.
An interesting breadcrumb for future research, but not something you'd change practice on.
Not based on this alone. It's a hypothesis, not a conclusion.
And we should probably briefly touch on the other half of that 2x2 design, the stent versus balloon comparison. We've been so focused on the drug, but did the device matter?
It did, and while it's not the main focus of our deep dive, the study also served to confirm what was becoming obvious at the time. Stenting is generally better than balloon angioplasty alone.
Better in what way?
Stents had significantly lower rates of restenosis. That metal scaffold does a much better job of holding the artery open and preventing that late scarring process than just stretching it with a balloon and walking away. That wasn't a surprise. But the key takeaway for our drug discussion is the interaction.
Meaning, did they work well together?
They did. It proved that it's safe to combine them. The stent plus Abciximab group had the absolute lowest complication rates of anyone in the first month. There was no negative interaction where the drug made the stent dangerous or the stent made the drug cause more bleeding. They were a great team.
Okay, so let's bring this all home. Part 6, conclusion and takeaways. We have analyzed the data, we've compared the trials, we've looked at the subgroups. What is the final verdict on Abciximab from the Cadillac trial?
I think we can synthesize this into a few really practical takeaways. First, in the short term, Abciximab is a clear winner. It makes the procedure safer. It acts as an insurance policy against those terrifying immediate clots. It virtually eliminates the risk of subacute thrombosis in the first few days.
So if I'm a patient on that table, I absolutely want it for the safety of the procedure. I want that 0.0% risk of my brand new stent clotting off.
You do, but, and this is the second big point, in the long term, it is not a magic bullet. It's not a cure-all for the chronic healing process of your artery. It fixes the blood, not the scar tissue.
Oh.
So don't expect it to prevent you from needing a checkup or even another procedure a year down the road.
It smooths the landing, but it doesn't necessarily change the final destination.
In a way, yes. And that leads to the final verdict from Dr. Chang and the authors, which is that the decision to use it should be individualized.
So it's not a yes for everyone anymore.
Yeah.
After this trial, it's not a blanket mandate.
No, it moved the field forward. You have to weigh the clear benefit, which is better procedural success and a calm, safe first month against the costs. And the cost isn't just financial, though these drugs were very expensive. It's the slight but real risk of a low platelet count and the potential need for blood transfusions if any bleeding does occur.
It sounds like it moves from being a blanket strategy to a strategic weapon.
That is the perfect way to put it. You pull it out of the armory when the clot burden looks high, or the anatomy is tricky, or you just need that extra layer of safety for a high-risk patient. But for a routine, clean, straightforward case, maybe you don't need the heavy artillery.
And this brings us to our provocative thought for you, the listener. We talked about time is muscle.
Yes.
And we talked about how the Admiral trial suggests that giving this drug early in the ambulance, an hour before the procedure, leads to better long-term survival. Why aren't we doing that everywhere?
That is the multi-million-dollar question facing cardiology systems today. It's a logistical and financial challenge.
Does the environment before the patient even gets to the hospital actually determine their life years later?
The data strongly suggests it might. The pre-cath lab phase is arguably the next great frontier in heart attack care. If we can start the potent medical treatment at the patient's doorstep or on the way to the hospital, we might be able to merge the procedural safety benefits we saw in Cadillac with the long-term mortality benefits hinted at in Admiral.
It makes you wonder if the future of interventional cardiology isn't actually in the operating room, but in the back of the ambulance.
It very well might be. The faster we can treat the blood, the more muscle we can save.
Well, we have covered a huge amount of ground today. We started with over 2,000 patients and a clever 2x2 design. We filtered that through the lens of 30-day wins and one-year plateaus. And we ended up with a really nuanced understanding of how trial design, timing, and biology all interact to shape medical truth.
The funnel effect in action.
Exactly. Thank you for watching The Funnel Effect.